Hi, everybody. Welcome back to the Holistic Pharmacy Podcast. I have with me today a very special guest, Mark Smith, the founder and CEO of Avalon Behavioral Health Solutions. Welcome to the show, Mark.
Thanks, Marina. Pleasure to be here.
Yeah, so you have a very non-traditional way that made you found this company, and you're not a pharmacist by background. So I'd love for you to let us know how you got into pharmacogenomics, starting from, where you grew up and your career trajectory.
Sure. To your point, no, I'm not a pharmacist. To my path to today to this call is very convoluted and very complex. I grew up in the human resources world. I was a generalist for Pfizer out of Manhattan. Then I did a labor job for the PepsiCo company out of Minneapolis. And then I was the chief HR officer for Blockbuster Entertainment out of Fort Lauderdale. I've lived in 6 different cities across the country. Blockbuster was acquired, so I came back home to Western New York, and I live outside of Buffalo. Yes, it does snow here. Um, and got involved in children's behavioral health. So this was my first aggressive turn into healthcare. I'm a layperson. I'm an administrator. I'm a business guy. So my first experience was I ran an agency with kids and families in the episodic mental health space. So you think your conduct disorder, oppositional defiant, ADHD, juvenile justice involved child. I was then recruited to run a very large agency in the developmental disabilities space. And when I talk about DD, some people kind of shrug their shoulders. If I use the diagnosis autism, everybody gets that. They can visualize that. So we had 2,700 kids in care on any given day, and 70% of them were on the spectrum. I realized quickly that even though autism is a phenotypic behavioral diagnosis, a child presents with autistic behaviors, there are about 40 underlying genotypes. So here's my leap in the genetics. There are about 40 underlying genotypes that will manifest as autism. So I used to tell my staff, literally, I'd hold my hand and say, we know half the kid. We know the phenotypic half, the half that's sitting in front of us. We don't know the genotype, the half we can't see. Until we put those two together, we don't have what I call the whole child. So I went off on a journey one summer of tracking down each one of the PhDs, MDs, who was the world expert in that one genotype. And that journey took me to Cleveland Clinic and Mayo and Vanderbilt and Emory and Johns Hopkins as I jumped across the country to say who's tops in P10, who's tops in SYNGAP1, who's the leader in Phelan McDermott. So in that journey, I got to meet all these very powerful, world-renowned researchers, but I also met the lab directors at all these various institutions. So if I'm talking to Dr. Kara Zhang at Cleveland Clinic about P10, I met the lab director at the Cleveland Clinic because that lab director was doing her research and probably hundreds of other projects just based on the size of the institutions. So I became aware of pharmacogenomics. Now we're getting to the end of the story in about 2010. I would say back then, PGX to me was somewhat of still a boutique science. The efficacy was not where it should be. The price points were not where they should be. But quite honestly, Maureen, I didn't care. I was doing my autism genetics thing, helping a lot of families. I just knew it was there, like I knew a lot of tests were out there. But then in 2017, my autism labs began to develop and launch pharmacogenomics tests. So for those of you out there that are deep in this space, Mayo spins out 1-ohm. Cleveland Clinic develops their test for their internal patient base. Mount Sinai spins out Sema4. So I started to see all of these labs that I've dealt with for a decade begin to launch pharmacogenomics tests. Two epiphanies. Number one, the efficacy was going to be airtight because these labs are not going to put out less than best in class science. And number two, there had to be a standard of care business model behind it. Let's just not create a test for the sake of creating a test. Let's create a test that's going to drive better health. And also, there's a business model behind it. So I launched Avalon in 2017 with the goal being to help drive PGX's standard of care. So that's how I got from an HR guy to involved in pharmacogenomics. And
Wow, well, that's quite a hero's journey there, Mark. I appreciate you sharing all of that. And obviously, it kind of has me wondering more questions. But what I'm really getting is like, it doesn't really matter what your background is in or what you think you are credentialed to do. I mean, if you're passionate about something, you can get involved in it, and it sort of like evolves and has a life of its own, and you meet people and you travel and everything builds on itself.
no, I tell people life is about fate. So I'm where I am today because of a lot of fate moments in my life. And you're
Yeah.
right, it's all about passion right now. I did my Fortune 100 career, so now it's about helping do something that really helps people have better health.
Yeah, I love that. So I want you to define for us, as a layperson, right, as you refer to yourself, what is PGX and what is the genome, and like what's the benefit of us knowing that for somebody?
Well, it falls into that bucket of precision medicine because we're all different, as you know. So the med that I take at a certain dosage size at a particular frequency is going to react differently in my body than it is in yours. Um, so all of my, I focus on four demographics, Marina, and all my demographic focus really comes out of a personal experience. You talked about passion and drive and fate. And all of my demographics, I look at large ends. I'm not in an individual practitioner's practice. I'm at more of an institutional systemic level. So my four populations are versus kids' behavioral health. And again, personal experience, I saw way too many 5, 6, 7 year olds that finally had the autism diagnosis on 5, 6, or 7 medications. And the combination of that was leading to poorer health and poorer behavior as opposed to better. So I'm not rank ordering these. I'm just laying them out. So one of my populations is kids' behavioral health, and there we use pharmacogenomics as a straight polypharmacy tool. Should this child be on these 7 meds, and what's the interchange between not only their metabolic rate, their genetics, but what's the drug, the gene. So we want to look at kids. That's number one. Number two is ambulatory surgery as a preoperative. Again, a personal experience. Um, I was a competitive cyclist. I had 4 significant spills. The first one, after they put my leg back together, I went home with 30 days of Oxycontin, which is what orthopedic surgeons do when you have significant surgery. Took the first prescribed dose and my pain wasn't touched. So I was able to jam a pharmacogenomics test through my insurance carrier just because I knew what buttons to push and bells to ring. And in our world, by our world, I mean in our PGX world, I'm what's known as an ultra rapid metabolizer of opioids. So I knew right away that that was not the best pain medication for me. Uh, um, Not I knew, I consulted with my physician. We knew. So my 3 subsequent surgeries, my body works perfectly with 800 milligrams of Motrin. So from a personal experience, I learned that there's many of us that opioids are not the pain solution of choice. And it turns out if you look at the research and the two ends of the bell curve, about 30% of the population, well, it's 28% of the population is either ultra rapid or poor. So you can make the argument that 3 out of 10 people should not be prescribed that opioid to begin with, and we should be looking at something different. So ambulatory surgery as a preoperative is population two. Population three is self-insured employers. Hopefully your audience knows what I mean when I say a self-insured employer or a large population of your audience. We are so medication happy in this society that 20% of people in that working age band of 18 to 65 are on 5 or more medications a day. It just blows my mind that if I'm walking through a grocery store, 20% of the people I'm going to pass are taking 5 different medications per day. So the argument for your large self-insured, and I'm going to do this backwards, not the way that I like to tell it. I'm going to talk about money first, and I'll talk about health. Typically, it's health first, the money will follow. So if I'm a large self-insured employer, chief financial officer, I now know that I have a way to find the meds that I shouldn't be buying. One of the meds that I'm buying through my self-insured plan, they have a metabolic challenge, have a gene drug challenge, have a drug challenge. So for the self-insured employer, it's let's get rid of the stuff that's not working. Here's a layman coming out me saying stuff. And let's also create a healthier workforce. And how do we know we have a healthier workforce? Well, we have three key measurables: return to work windows pre and post. When I say pre and post, pre PGX implementation and post. So how long were people out for injury or illness before they were put on the right medication? What was the attendance pre and post? So did the attendance numbers go up? Did people come to work more often because they felt better? And then how do you measure productivity? Every company measures productivity. How do you measure it? And we're going to create a more productive workforce, particularly in your behavioral health meds. So if you think you're antidepressants, anti-anxieties, antipsychotics, if you're on the wrong behavioral health meds, your productivity is not very good. So that's population three. The fourth is probably where I could spend all my time, and that's seniors. And when I say seniors, I mean at any treatment location. They could be home, they could be in a continuing care retirement community, they could be assisted, they could be skilled, they could be hospice. I think all the pharmacists on this podcast know the polypharmacy situation. Seniors is egregious, to say the least. Number one cause of falls is not the walker or the throw rug, it's medication combinations. And I've got two research papers. It's either the third or fourth leading cause of death, 80 years. So neither number is good. So we're not only knocking our seniors off their feet, but we're also to some extent leading to earlier deaths with all the crazy polypharmacy. So again, 4 demos: kids behavioral health, ambulatory surgery, self-insured employers, seniors.
Yeah, all great points that you have been making, and really good description of who will benefit from this the most, and that's who you're focusing on. So, a couple of follow-up questions based on that. Well, I love, first of all, that you chose the opioid, right, and the pain management as an example, because everybody is aware of the crisis of overprescribing and the opioid addiction. So this is off the bat just a good idea. And then also to find out, if not an opioid, then what pain management would work for a person. So that has a very clear application right there. So that makes me wonder, could you tell us about what other applications might there be besides what you already covered in polypharmacy that we could be using these genomic tests for? Because we know pharmacogenomics specifically is about pharmacokinetics of the drug, right? But what about other things that we could potentially use these results for? Are they only drug related? I know there's nutrigenomics, so maybe if you can talk a little bit about the wider applications here.
Those are areas that obviously I'm aware of based on what I do, but I'm trying to stay pure to PGX at this point because I do want to get it to that brass ring of standard of care. None of us should be consuming any pharmaceutical, regardless of the cost, the complexity, the specialty nature, until we know that it's going to work. We're actually in discussions with the Children's Hospital right now to do a buccal swab at birth to get a PGX profile at the point of birth. So I mean, everyone has that epiphany when they get it. I got my PGX test when I was in my 50s. So for X numbers of more years, I have the ability to apply that to my health as a self-advocate. I had a son who I got his test when he was 17. So for my son, he's going to have that ability to self-advocate on his own health, hopefully for a lot longer than I will. So there's this journey of how do we keep pushing down the lifespan when this very valuable information is captured. The other thing that I do, I work with 5 different labs. The other thing I do in my model is all of my labs have to curate their database against guidelines. So as the pharmacist on the phone knows, so when the CPICs of the world, the PharmaGKBs, the FDA on a med, the Dutch Pharmacovigilance Group, as they come out with new guidelines, all my labs then update their databases, which then go out and populate everybody's report. So all of my reports are dynamic and live. So it's not a snapshot in time like a blood draw. It's a test that, should there be a med that didn't exist at the point you had your test, or should there be a change to a guideline of an existing med, you know that, and we also only work with these magic things. You also know that as you go forward, you can be in a prescribing event And until we get to that dream of interoperability with EHRs, you can coach and counsel your doctor on the effectiveness of that med in the moment. And just as an anecdote, myself, my wife, and my son have had multiple conversations where we've pointed out a metabolic problem with the med that they're ready to prescribe.
Yeah, thank you for sharing the real life examples. That's always helpful. I know for myself, I did the 23andMe back in the day when it was just coming out, or like maybe a couple years after it came out. And the difference, like you said, with a blood test, right? It just shows you a moment in time. Like this
Right.
shows you something that you have the genome, right? The potential of expressing, right? And then as they get more advanced, all you have ever had to do is just take that one test, but then the real time information gets updated with new information. So you kind of alluded that, but for the PGX labs out there and the standards of testing, have all drugs so far been categorized in there and sort of or does it differ on the lab? And what happens to like Me Too drugs? Every single one of them has to get sort of tested.
Well, if you talk about the panels, if you talk about, how many drugs we cover in a given panel, again, here comes the layperson to me. I call my panels my box of Legos. You tell me what class of medications you want to look at for that individual, and we can reach into that box and click those genes together. Um, my full panel today, I'd have to go look at the database. It's probably 150 to 200 meds, but we can break that down by cardiac, by behavioral health, by oncology. So it really depends on what specialists we're dealing with and what they want to look at. Now, obviously, for my family and what we take direct to consumer is the full panel because we want you to have the full utility of any prescribing event that you have in your life. We want to up the possibility that you'll have some guidance for them. To answer your question?
Yeah, that's really helpful. So I guess the question is like, as new drugs are added to the market, like you alluded to, that the labs are doing work in real time to add them to their
Correct.
sequencing.
Right.
Yeah, so it's really fascinating because it sort of becomes a part of how we do healthcare, right? Because we're already, like you mentioned, so bought into the standard of care, right? To the allopathic prescription-based care model that everybody after a certain age or even from a young age, gets prescribed antibiotics, gets prescribed,
Hmm.
cough medicine, like all kinds of things that we get prescribed on, and we don't even like think it's a big deal, but all of these have a potential for side effects and interactions. And so getting this type of test will allow us to not prescribe something that will already, likely cause a negative event or not work as well. So I really like that idea. And then you have that card, right, sort of to carry around that you can take, wherever you're getting care. It's part of your profile. I don't know if it's already like a digital format, right, that gets into like a database that doctors can easily access, or if there's a ways to go in that tech aspect, but maybe you can let us know.
Yeah, right now, I mean, so many medical practices work on so many different electronic health records that interoperability isn't where it needs to be, where I can embed my pharmacogenomics report within the EHR at that practitioner. What we often see happen, and what has happened in my life is the practitioner gets the portal report and just sets it up in a separate browser. So if I go to my neurologist for I've had some neurological situation I'm taking care of. She'll open up her electronic health record to get Mark's clinical information, but then another browser, she'll open up my PGX portal. So she'll get to the point of prescribing and she'll click over to the other browser and say, okay, how does this med that I'm thinking about prescribing lay up against Mark's PGX profile? The ideal, Marina, is they're embedded. It's interoperable. It's right there, particularly in long-term care. If I can build a model that you're loaded into the EHR when you're in home based, and then that follows you to assisted, follows you to skill, follows you to hospice, so that the providers have this longitudinal, seamless prescribing tool in the background. But we're not there yet. I mean, that's part of the journey is to get interoperability with multiple. I mean, about the big ones, the Cerners, the Epics, the Allscripts, that's probably an easier lift than the hundreds of different. I mean, even in your world as a pharmacist, there's different health records in different pharmacies, and some are proprietary and some aren't. And so, no, we're not there yet. But we do put your report into an app, so you can take it with you, and even though it's not interoperable, you can open up your report and hand your little magic phone to your provider.
Yeah, you bring up a great point about the interface and making it more like universally accessible. And right now, currently, pharmacies in the retail settings are usually not part of that equation. Like maybe institutionalized pharmacies, right? And long-term care are. But that's another piece of the conversation where we're actually the ones dispensing the meds. So we should probably, as medication experts, have a say or have like that consulting role, or that final check before dispensing, just double check, okay, does everything line up? And so my question for you is, you know, where do you see the gaps, right? What gaps are still out there that you would want to fill in the ideal world? What opportunities are there for pharmacists or other companies to fill in those gaps? And then what is your company currently doing? Like what are you providing?
I think that the dream of the acronym is HIE, Health Information Exchange. So there's this idea out there that we're going to build this neural network of this EHR database that talks to all of the providers within some geography. So my record's in it. So when I go to my dentist, it's there. When I go to my neurologist, it's there. When I go to my chiropractor, it's there. And when I go to my pharmacist, it's there. Those haven't really come to fruition yet. The HIEs out there are struggling and they're making some connections, but creating this utopic umbrella over Marina's healthcare. So wherever she goes, everybody will know what's going on with her from a clinical standpoint. What we're doing to kind of chip away at that is we launched a direct-to-patient PGX website August 1st. And what we're telling the patients when they, here, prop time, when they get their buccal swab kit in the mail and you fill out the paperwork on the inside, including the HIPAA paperwork, but when you fill out the who do you want your report portal to go to, obviously you're going to provide us your email address, but we encourage everyone in the collateral, include your pharmacist. Because there are healthcare practitioners in this country that are specialists that look on you in kind of a niche siloed way. Then there's healthcare professionals that look on you holistically and the whole human and overall health, and it may not need a drug. And I put in that bucket pharmacists, I put in that bucket chiropractors, I put in that bucket psychologists, I put in that bucket physical therapists. To some extent, even though they prescribe, dentists are much more holistic than a lot of your specialists. So we're very aggressively working with those. I don't want to give them a label, those holistic providers that say, Mark, I'm concerned about you as a human being. I'm not your cardiologist. I'm not your nephrologist. I'm not your neurologist. I'm concerned about you as a whole human being. So now that you've shared your pharmacogenomics report with me, I can tell you this is the conversation you need to have with your cardiologist. This is the conversation you need to have with your neurologist. Because some of these, like pharmacists, I mean, I'm sure there's been a lot of adversarial conversations that have happened between pharmacists and doctors because the pharmacist knew there was something that wasn't appropriate for that patient. And they get on the phone and they try to advocate, and either it goes well or it doesn't. You're nodding your head because you've probably been in those conversations. So we want to equip these holistic practitioners with as much solid evidence as we can. So, hey, this person has a variant at 2D6. That variant at 2D6 makes him an ultra rapid metabolizer of opioids. You shouldn't have this patient on an opioid. He's going to go through his 30 days in 10 days to cut his pain.
Yeah, I appreciate that, and I certainly have been on the end of the pharmacist in those sides of the conversation, and the point being that pharmacists are sort of like a mid-level practitioner in this country where we're not a provider, right? And we are supposed to dispense, and we're often seen as like a barrier between somebody receiving their care, right? We're like in between them and their doctor. But the idea is that we provide the checks and balances, that we're not a barrier, but we actually make sure, right, and give a second opinion, and provide the correct access to the correct care. So we're like that last line, right, between whether the patient is going to get helped or harmed. So that's the bottom line. And like I'm seeing this, as an opportunity for pharmacists to get involved in, and I know a lot of pharmacists have started to get involved in PGX, and I believe like they are the perfect professional for this. So where do you see this going as far as like you mentioned the sort of holistic practitioners and professionals and others and us all working together, but then we also from like a monetization standpoint see you do this test once, right? So where does like the repetition, right, and the service-based part of the service come in?
If you talk about adoption, and again, as a layperson, I create a lot of silly references. And I think for any clinical solution to get to standard of care, you have to engage what I call the 4 Ps, the letter P. The first P is the patients. What in the broader population, how many people know about pharmacogenomics and know about the individual value that it has to them? So how do we engage with patients? Second is providers. How many MDs? I mean, even today, Marina, I could call an MD and mention pharmacogenomics and get a what is that response? So the breadth and depth of knowledge in the MD population needs a lot of education. Third is your payers. So the third P is the payers. And it's not only your government payers out of CMS like Medicare or Medicaid, but it's all your commercial insurers. One of the beauties of the self-insured population is they write their plan document. So it's not like I'm buying a community Blue Cross Blue Shield plan. I'm the health plan sponsor. If I want to put pharmacogenomics in my plan, I'll put it in. I'll tell the TPA, the third party administrator, it's now a covered benefit. But if you look at the commercial insurers, United's written in their commercial plans for behavioral health meds, so they have one class of meds. Blue Cross Blue Shield in Michigan is doing a pilot with one ohm. But other than that, there's not a lot of commercial insurance adoption. Fourth population is the politicians, or the fourth P. And there it's the challenge of we don't have, yeah, we maybe do have a drug price problem in the United States. Maybe meds are too expensive. But the bigger challenge is we have a consumption problem. We are all consuming too many meds. And if you talk about overall drug spend's got two variables in it. It's consumption times price. And if we're going to spend all of our time trying to take a pill from $10 to $9, but maybe Marina shouldn't be taking that pill to begin with. So now rather than saving $1, we save $10. So I spend a lot of time with politicians saying, you're ignoring the consumption variable, hence you're ignoring health. Because cutting the price of a med doesn't make someone healthier. It just means they spent less money. So when you talk about adoption, my 4 Ps, the patients, the providers, the payers, and the politicians. I would say the biggest barrier today is the payers. As the payers come on board and more patients can have it reimbursed, even though the price point, I don't know, Marina, how long you've been around pharmacogenomics. When I first got involved, a commercial lab would have been $1,100, $1,200. I can get tests now for under 300. So that's why we approach this direct to consumer idea, because it's not 23andMe yet at 100 and a quarter, but it's now at a price point where the lifetime value is worth it. So what I bought for myself and my son, the fact that I paid $700, the value for that is immeasurable. He'll be 45 years old and he'll be in a prescribing event and he'll be able to coach and direct his prescribing physician on whether or not that meta work.
Yeah. And so part of what I was wondering, so with the adoption, right, into a larger healthcare setting and systemically, how do we keep the profits, right? And like, how do we make it more about the service to the patient rather than just testing them and charging them once? Like, is there a way that you interpret the results? Should every practitioner get trained like independently, or should somebody just provide the service of like, let me interpret these results for practitioners? Like, where do you see it nowadays, and where do you see it going?
The reporting has really evolved over the last 7 years. And when I got involved with this, every lab put out a very onerous, I'll use the number 40, put a very onerous 40-page PDF. And it was chock full of helpful information and valuable clinical information. But the patient would get 40 pages and go, what does this tell me? I don't know what to do with this. And the doctor in a fee-for-service environment, by that I mean I have 10 to 12 minutes before I have to move down the hallway. All right, I'm in this prescribing event. I have this 40-page PDF. I can't make a clinical decision. So we put a lot of effort into tech and taking the PDF and retiring it and making the results now a searchable portal. So I can go onto my portal and plug in a med, plug in a class of meds, plug in a med I'm not taking yet, plug in a med that my doctor's thinking about, and I can get right to that data instantaneously as opposed to thumbing through a PDF. All right, what page is the cardiac meds on? So we've come a long way there now. Haven't been in genetics for a while, starting in autism. Every genetic test, regardless of what it is, it's BRCA1 for breast cancer. It's an autism genetic. Every test has the ideal translator who can take those results and explain them to the patient and explain them to the provider. In PGX, that ideal translator is a pharmacist. It's not a genetic counselor, it's a pharmacist. Because who's been trained clinically to understand the interaction between that med and that human being, and then who has the ability in and I say this as a compliment, in a layman way to explain to the patient what that means, what that ultra rapid metabolizing means, because that's a lot of syllables for me. And then on another call, have a clinical variant specific genetic conversation with the provider. So in the PGX world, my go-to people when I'm in one of those, because I'm a lay person, when I'm in one of those stuck conversations with a doctor, I get one of my pharmacists on the phone. And I say, here, talk to this individual. This person is not only an expert, but it can explain it to you in a way that's actionable for you. Because we want the docs to learn and then take the right action.
Yeah, exactly what I'm thinking. And I have a lot of pharmacists in the audience, so I'm just going to ask what they're probably all wondering. How do you make this sort of service, whether you're consulting a practitioner, prescriber, or the patient and the consumer, how do you actually make this a sustainable part of your services, right? Bottom line is a payer has to pay for it. So who's going to be paying for that, right? You said that's the biggest hurdle. So do you think this is something that right now the patient is going to be willing to pay for? Or like, how do we start to change perspectives around this?
Yeah, in the payer evolution, uh, our revenue, Avalon's revenue, comes from Medicare, because Medicare will pay for cardiac and behavioral health meds. So if I have a senior who's on a cardiac class of med or behavioral health med, it will come from self-insured employers, because like I said, they can write PGX in their plan document. It will come from, if I use the acronym Continuing Care Retirement Community, I don't know if everybody knows what a CCRC is, but those are the institutions across the country that charge a very large upfront fee for you to reserve your space on their campus. And then once you're on their campus, it's a continuum of care, unfortunately, until hospice. They are starting to use PGX in their intake/welcome packet because they feel that I'm going to use 300 as a round. They're going to feel that $300 that they spend to welcome the patient to their $500,000 entry fee goes a long way, number one, to building goodwill, because they've immediately at day one given the new resident something that's incredibly valuable. Number two is a competitive advantage because somebody else isn't doing it. But the hidden agenda is in their seamless electronic health record, that's going to follow you from your garden condominium to your time in assisted, to your time in skilled, to your time in hospice. So we're seeing revenue out of the continuing care retirement communities. We're seeing revenue now out of the direct to consumer. If I'm allowed to do plug for my website. Everything I'm saying is there if people want to just go look at it. So how does someone buy a direct to consumer test? What does that look like? The instructional videos are there. I mean, it's all self-contained. And for your audience, it'll probably be a good learning tool for them to go and just bang around on my site and look at the videos and look what's up there. I don't care if there's any activity, but if they just want to go to my site. For the payers, commercial payers, it's still a struggle. And I don't know why, Marina. I don't know why. If I'm the chief medical officer of Blue Cross Blue Shield, fill in the blank, whatever, why wouldn't I want to implement a tool that does two things? Better member health. So my member, my plan is going to be healthier. And as a commercial business, I'm going to spend less money. Everybody thinks on pharmacy. It's not just that. I've got so much research on what it means to quadruple aim of just health. So there's one, I don't know if it's on my website. I'll look. They did a comprehensive pharmacogenomics test on 5,000 Medicare Advantage members. So they took 5,000 people, gave them all PGX, did all the affiliated medication adjustments. So what did the pharmacogenomics test say about Mark? Let's make adjustments. Then they tracked them over a trailing 12 months. The overall healthcare spend, not farmer spend, we put that aside. The overall healthcare spend went down $2,625 per person. And that was just because they were healthier. Diabetic numbers were better. Blood pressure numbers were better. All the measurables in the clinical record got better. So as you talk about math, there's 30.7 million MA members in this country. If every one of them got them a $300 pharmacogenomics test and we saved $2,625 per person, I don't know how many billions that number is.
Yeah. Yeah. So it sounds like there's still like not 100% buy-in or validation of that savings because yeah, you'd be a fool not to do that. Um, so I definitely want you to share about how listeners can learn more about you and get in touch with your company. But before we do that, I'd love to do a rapid fire round of questions with you, Mark, if you're up for it.
By the way, it was a lot.
Okay, so let's have some fun with these. I asked this, you know, I give random questions to all my guests, but some of them overlap. So the first question I always ask is, if you had to give somebody advice on how to improve their quality of life right now, what would you say?
Exercise, movement,
Love it. Question number two, what is something that you do for fun or that's your hobby?
exercise, movement. After we get off this call, I'm heading to I have a gym in the house. I'm heading to the gym for 20 minutes just to take the BP down a little bit.
Love it, love it. And finally, what's your favorite meal to cook and to eat?
Ooh, interesting. I love to grill, so I don't know if there's a specific protein. Like tonight, I know I'm grilling chicken. I made steak over the weekend. If I go out to a restaurant, I'm a big Mexican fan. I spent time in Dallas in my corporate career and really got hooked on authentic Mexican. So if I head out, it's probably going to be Mexican, but if I cook at home, I'm a grill guy.
Love it, love it. Well, Mark, I want to thank you so much for your time today, sharing your wisdom, and I would love to give you the opportunity to just let people know who should reach out to you, what exactly can you help them with, and sort of just give us a little elevator speech about your platform.
Okay, I'm gonna give you two websites, and I'll slow down my New York speech and do this as slow as I can. One, obviously the www, but Avalon, Avalon, PGX.com. So AvalonPGX.com. And then our direct to consumer site, which is packed with even more videos, is ismyrxsafe.com. So ISMYRXSAFE.com. So if you go to ismyrxsafe.com, again, from an educational standpoint, you're going to see all the videos. And it's pointed at the patient. So for some of your pharmacists, they're going to look at it and say, this is somewhat simplistic and almost cartoonish. That was intentional. If I have some 75-year-old senior on 13 meds on my website, I want them to get it. And so we intentionally made it, here, I'm going to do a quick little prop here. Here's the app. Yep. I don't know if I can get the focus. Nope, it's not focusing. So that's the app that everybody gets in their phone if they buy a direct to consumer test. And this is what I take to doctor's appointments.
Yeah. So essentially, you're like the interface between the provider and the patient, and whether it's a pharmacist or prescriber, they can use your platform to order tests and to interpret it. Am I getting that right?
They can, or the patient can do it directly. We're trying to make we've all heard the cliche in healthcare, the patient is the consumer, the patient is the customer. And unfortunately, the history of healthcare, no, we weren't. The patient was the pawn of the physician. The physician told you what they were going to do to you and why they were going to do it. What we're trying to do with DTC PGX is make the patient say to the doctor, no, you're not going to prescribe me that med because according to this magic little box in my hand, I had a variant at this gene, which will cause me to. So, sure, docs can prescribe. One of my dream states is to put kits in end caps in pharmacies. That's the dream, because then the pharmacist could say, hey, while you're here filling your whatever prescription, I think you might want to take a look at what's on the end of aisle 7. And if you end up making a purchase, please put my email on the release documentation. So when you next come in here, I'll be able to have a much more deeper clinical conversation with you around whether or not that med is effective. So we've had some talk with community pharmacy associations around that, but we're not there yet. But I just love the interchange between pharmacist and PGX. I mean, it's where it's got to go.
Yeah. Yeah. It definitely sounds like a more of a behind the counter item because of the price tag. So, but I love the idea of making it available in pharmacies, whether retail or perhaps other pharmacy settings.
I didn't
So,
think the shoplifting angle, Marina. But the problem, the lab's not going to activate your kit and do the sequencing if it has been paid for. So steal the buccal swab, go home and play with it. It's not going anywhere.
That's really funny. Okay, cool. Well, regardless, it's something that is, like you said in the beginning, not well known yet. People may not see the benefit as we've been talking about. And so there's a lot of education to still do and prove the value, which obviously there is, and have it more accessible to patients and ideally through pharmacists who would be the perfect role for this. So thank you so much for this conversation. Any closing words? And I'll be sure to share all the links in the show notes.
I have been on this journey now for over 7 years, and I look on every conversation as the opportunity to create a PGX disciple. So hopefully you and however many members of your audience will pick up that flag and help spread the word on the clinical value. It's, when I talk to business leaders about it, I often get why isn't this available now? I mean, I get that question all the time. Why isn't this available now? Why hasn't this been available? So if I've got a cadre of very bright pharmacists out there echoing that concern, adoption is going to happen quicker. The more people talk about it, the quicker it's going to happen. That's why we want patients talking to doctors and neighbors and fellow parishioners and grocery store trips. And so, I can stop somebody and say, hey, I'm a rapid metabolizer of opioids. And to me, that's not that confidential of a thing. It is what it is. Now I feel like I'm off my soapbox. I apologize.
Thank you so much. Yeah, it's the consumers, like you said, that drive market demand. So the more we demand it, the more we have a chance. So thank you for advocating, and I wish you a pleasant day ahead.
I'm around for questions.
Okay, thank you. Bye-bye.
Take care, Maria.